So let me introduce our folks from Placer, Nevada. The leads there include Lindsay Coate and also Dr. Rob Oldham. And Lindsay is the executive director of the Placer, Nevada County Medical Society. And they are the lead organization in this coalition. And Dr. Oldham, he is the health officer and medical director for the Placer County Department of Health and Human Services. And we're glad that you are both here.
Great. So I think we're supposed to stand right here, so we're on the live stream. And so we're just going to kind of tag team this, and I'll start just talking a little bit about this strategy that we had with our Opioid Safety Coalition as far as involving law enforcement. And so one, we see them as a great distribution point for naloxone. They often are the first people to show up at an emergency, like a medical emergency even. The ambulance comes, but often law enforcement are the first there. But also they're tremendous leaders in our communities. And so from public health, we're already have relationships with all of our police chiefs, our sheriff. They're some of the most popular people and some of the most influential people in our communities, particularly in rural communities. And so this was really a strategy, not just for the naloxone distribution, but involving them in our whole, the whole coalition. In fact, we have a number of members of law enforcement who have, just like all of us, their own kind of personal connections to this issue. And so we, when we were setting up our coalition, we really patterned many of the action teams after, RX Safe Marin and stuff. But we decided we wanted to have kind of our own first responder action team with not just ambulance and fire, but also law enforcement as part of that. So we invited all of our police chiefs to be actual members of our steering committee, and we have created this first responders action team made up of police, fire, and emergency medical services. And then we, with public health, we already had a lot of these relationships formed. Lindsay with the medical society, she was actually on the board of the women's shelter and knew one of the other police chiefs. So we really kind of used our whole coalition to make connections to get people in high levels of law enforcement to the table. And so as really the achievement of this, there in the last bullet, all of our police departments are represented in the steering committee and the coalition by either the police chief or an officer or their community relations representative. So we really felt like that was a real strength of our coalition. So as Karen Smith says, we're public health. We have to have at least one data slide. This was actually our attempt to try to engage law enforcement on this issue. So we said, well, let's pull some data from our local EMS agency. And so really all the counties should be able to do this. The EMS keeps really good data. And this is on, I don't know if you can see this or not. We have kind of 3 different graphs. But this one, both of these here, I'll just kind of point, are response times for different agencies. So the blue is law enforcement and how quickly law enforcement gets to the scene from the time of kind of call to dispatch. So a little over, like 4 minutes and 40 seconds on average in Nevada County, and about 5 minutes in Placer County. And then you see the orange bar here of fire department and the gray bar of ambulance. And then the yellow bar is the time from dispatch to the administration of naloxone when it's indicated. So you see there is kind of a lag there in the time of when somebody shows up and when the naloxone is administered. But when we looked at the data and presented this to our emergency responders action team, I was a little worried because to me as the public health guy, I was like, well, it's not a compelling reason, for law enforcement to have it, particularly given this graph here that shows that really, like in Nevada County, a minority of the cases where naloxone is administered is law enforcement even involved showing up on the scene. So anyway, we took this to the first responders action team, including a lot of the police chiefs, and I was kind of worried. I'm kind of sheepishly saying, well, there's, and I was actually amazed by the response of the police chiefs, and one in particular who said, you know what, they're really action oriented. So this is kind of the other takeaway from, I think, from our talk is the police chiefs, they're powerful leaders in your community, and they also just want to get something done. They don't want to come to a bunch of meetings if they're not going to get something done. So they said, no, even if we can save one life, we're going to do this. And so they really made a commitment to pilot this. And so initially in the community of Grass Valley, which is actually in Nevada County, a community of about 12,000 people. So it was decided that was kind of the ideal place for us to pilot this. But really there was buy-in among all the police chiefs to do this. In Grass Valley, there's only one hospital for this small community. And the police chief had a relationship with the hospital, and they agreed to pay for all the naloxone for their small police force for Grass Valley. So that was kind of the first to go. And here the slide is on this pilot program with the Grass Valley Police Department. And here is the device that actually we decided to use up there, because it's also, so this is the intranasal mucosal atomizer. And this is the same device that they already had in the ambulance rig. So we decided that would be probably the best way to go for lots of reasons. One of them is they kind of worked this deal with the ambulance that, the hospital is going to be paying for the police to have these atomizers, but when they used it, when the ambulance showed up, they just give the law enforcement would give the used atomizer to the ambulance people, and then they would give them their unused atomizer to replace it. So we kind of had a replacement strategy with the understanding that really the ambulance, if the law enforcement didn't provide it, they would have had to use it anyway. So the ambulance agreed to kind of fund the replacement through that mechanism. Lindsay, you have any? Yeah, take over, Lindsay.
I need the mic. Oh. Okay, so the officers are also supposed to keep track of the expiration date. A big concern with a lot of the police forces with starting this pilot program is what are the protocols. So Grass Valley has created a really nice protocol to go by that we're willing to share with any other police forces that are interested in getting this started. So like I said, the officers are to keep track of the expiration date for the package, and the medications should be turned in at the end of every shift to avoid becoming overheated. I think that was the biggest sticking point for most of the police departments in starting this pilot program is, if we leave this in our cars, what happens to the medication if it becomes overheated? It can only go up to a certain amount. So the idea is to put it in whatever pack they take when they start their shift and leave it in that pack and then turn it in at the end of every shift. And in the event that the medication does become overheated, they would simply replace it a few months earlier than what the expiration date has said. So like I said, I do have the protocol right out of their policy handbook. So anybody that wants that information, I am happy to share it with you. So just want to go a little bit into the training that the Grass Valley Police Department received. We brought in one of the CMO from the Western Sierra Healthcare Clinic, and she went over about an hour of training from the SAMHSA handbook, or the 5 essential steps for first responders. And I won't go through all of it, but you can look it up online or on our website. You probably all have it for your own coalitions.
Sure, and so I mentioned that the paying for the program with Grass Valley, the Sierra Nevada Memorial Hospital donated kind of the first batch, and like I said, the replacement strategy really was for the police to take on the cost of replacing the medications, but the ambulance would actually replace it when used on the scene. So really the police were responsible for replacement, as Lindsay said, and other times when, for instance, it's overheated or something like that, but just for if it was used, then they didn't have to pay for that.
Okay, so we're also working with the Roseville Police Department, and this is a much larger police department, so we're still going through the administrative process with them right now. But so far, they're going to be receiving training from the SSV-EMS agency by Dr. Troy Falk, who is their medical director. And they will be using the Narcan spray. It's a much easier device to use when in the field. And the Placer Nevada Medical Society, which I represent and is the lead on this coalition, we will be paying for the first batch of naloxone for the entire police force. But after that, the police department will take care of the cost of replacing the medication if it's used in the field or when they expire.
Yeah, so I guess kind of in summary, really, key, as I mentioned, buy-in from the police departments was really required for this to happen, not just for the Naloxone program, but really for our whole coalition to get them as leaders in our community on this issue. So when we did a media event, we had the white coats, but also had the blue, the uniforms from our law enforcement there, and it really had a significant impact on this issue. As I think even shown in Little Placer in Nevada County, we couldn't get consensus on which device to use. So I think it's acceptable to use different devices depending on the different police departments, maybe the different ambulance service providers. But it's generally nice if the costs, and when we look at the different products, really the costs are about the same. It's about $75 for the pack of 2 for most of these different products. But the other take home, and I really appreciated this, is from Chief John Ruffcorn for the Auburn Police Department, who really said, even saving one life is worth the cost, and really helped us to reframe this. We were trying to make this kind of compelling case for them, and to realize that the police officers really do, they're on the beat every day, and they really are critical allies here, and really can get this issue and understand the impact of overdose deaths in our communities. So with that, I think we'll stop and answer any questions.
Great, thank you very much. Okay, so we have just a couple questions online, and then I want to get to your question too. Kelly, you want to?
Sure, Kelly Piper. Thanks for Remote Sites for calling in these questions. One was, if you in the community give naloxone, should you also call 911? And do you want to answer that question?
Yeah, so that's certainly part of our training when we're looking at having distribution sites, right, is whenever you use naloxone, you should call 911. We actually just, you might have read about the fentanyl overdose deaths, kind of street fentanyl in Sacramento area, and so we were impacted to some degree in our counties as well from that, and recognizing that even when someone, recovers and looks like they're doing fine after a Narcan administration, we all know kind of clinically that often they'll start to have another event. So always, that's part of our protocols, always call 911, even before the administration, right?
And I was just asked to define all these terms for the non-clinical people. So naloxone is the overdose antidote, Narcan's the brand name, Suboxone is a product that's got both buprenorphine and naloxone in it, and the whole point of that is that when you take a pill with naloxone in it, it gets inactivated in your stomach, so the naloxone doesn't do anything. But if you take that pill, grind it up, and shoot it, then the naloxone becomes active. So this is what's called an abuse deterrent formulation, which doesn't prevent anyone from abusing something by mouth, but if it's injected, it would have an unpleasant side effect. So in any case, other questions?
Great, thank you. Okay, so can you introduce who you are?
Sure. Gina Anderson. I work with El Dorado Community Health Center. Quick question on the prescribing. If the police departments are going to be purchasing it on their own, who is it under the public health officer's authority, prescribing authority, or how does that work?
They'll have to have it prescribed by a doctor. A doctor will have to actually purchase it.
Who are they using? I guess who's the police department using? Because like EMS agencies have medical directors.
Mm-hmm.
How does that work?
Well, for the Grass Valley Police Department, they're utilizing a physician at the hospital there. For the Roseville Police Department, we haven't gotten that far enough into the process with who's going to pay for it after they go through their first dose yet. So, but yes, a physician will have to basically volunteer to purchase it and put it on their license.
And so, yeah, the resources there, it's similar to things like EpiPens, where we just went through this. So the local health officer, so that would be me in Placer County. So kind of I'm available to do that and kind of have to assure that they're getting appropriate training. The local EMS medical director as well. So I know both of us are willing to do that. We just haven't kind of decided who in this case is going to do it. He's actually going to be the local EMS medical director will be personally involved in the training. So that's probably the best. But whoever that is, the physician really should be at least have some involvement, understand that in the training.
There's a question over here.
Hi, my name is Natasha from Lake County Public Health, and I'm just wondering if you have had any opioid reversals yet with the Grass Valley Police. No, okay. Thank you.
It just started.
It just started.
Okay, we have one more. Oh, Steve and Marisol.
So Steve Wirtz from Public Health California Department of Public Health. Sorry. The question is about liability. I've been hearing some people saying they're resistant about getting into the standing order or whatever. How are you handling? Are there issues of liability, and how are you handling?
Yeah, so in this, I alluded to the EpiPen thing where all the schools have to have EpiPens. And so I got my, in the counties, it's, you go to county council and get your lawyers to clear this. And so they kind of cleared it for EpiPens. And I would argue we haven't done this, so I haven't been required to do the standing orders for Narcan yet, probably will. But I would argue in this case, the same way I did on the EpiPens, that the liability of, that there's much more risk in them not having access to it. And so, yes, there are some potential adverse events that can happen with administration of naloxone when it's, shouldn't be. And so potentially there's some liability there, but I think in general the county is willing to kind of take on that liability, and likewise the local EMS agencies, or even just private, some private doctors may be willing just to take on that liability. But yeah, it's a consideration, and I think the doctors need to talk with whoever it is, usually their attorneys or their medical malpractice carriers, to keep them in the loop. But generally I think what I'm hearing is a pretty low level of additional liability that they would incur.
We have 2 questions back here, and then we'll move back up there.
Hi, Marisol Zamora with Fresno County. Just wanted to ask, did you have any challenges from law enforcement or any pushback from law enforcement to administer naloxone? And if so, what were they?
So far, no. That was easy.
And I guess it's a very hierarchical organization. And so we started with the chiefs.
Okay.
And who they had they thought it was a great idea. In fact, we were kind of the ones who were saying, are you sure you want to do this? And, we couldn't talk them out of it, basically.
Question back here.
Hi, Rachel McLean, California Department of Public Health. I wanted to just address the question about liability. So there is a Good Samaritan law in California. So California law explicitly says that there is no liability for physicians who prescribe naloxone, both for the patient, but also for the patient's contacts. So standing orders are allowed, and there is no liability. Just want to make that very clear. And then the question that I had was, has there been any consideration of training sort of friends and family members and drug users and other people in the community? Just because we know that there is, obviously people are sometimes engaging in illicit drug use, and they may not always feel comfortable calling 911 in the first place, in which case, if neither police nor EMS is there, then, there's lots of evidence showing that drug users and friends and family members can safely administer naloxone. I'm just curious if that's something that you're looking into doing in your county.
So in short, yes. So this, I think it was alluded to in some of the previous, from this morning. So that's something that we're looking into. We actually have kind of tentative approval at the county to try to, roll this out, for instance, at our homeless shelters, to have, peers, even in our mental health system, we have kind of a robust peer advocate program, and that those would be potentially people, they don't really need to have a medical nursing type of background, that they could have doses of naloxone available, or like you said, family members, or obviously people who are experiencing addictions. And so, yeah, we're exploring that and are pretty far along in that.
Yes, we're looking at naloxone distribution sites. That's what several of the northern California rural counties are actually working on right now. Our community-based prevention team, that was one of their goals, is to get more naloxone into the community.
So just a couple more questions, and we'll switch over.
I think you said it's been a very short period of time, but can you say how long the Grass Valley pilot's been in place, if they've utilized, if any of the officers have actually done an implementation with it? And then finally, if you have any idea of what the annual budget estimate the department set aside for the replacement?
Sure. There's only 30 police officers. There's less than 30 in Grass Valley. So you can imagine it's a few $100s really for the Grass Valley Police Department. That's why Roseville, we're still in the red tape process of figuring out how to pay for all of it after we buy the first dose. The program has only been in place for a little over a month. So I haven't heard that they've utilized it in the field yet, but yeah, I just haven't heard anything.
Yeah. And I would say from our epidemiology, our numbers, we wouldn't expect them to, right? So it's a rare event for that community. So maybe 1 or 2 a year in Grass Valley would even be utilized, is what we would expect.
So we have time for just one more question, but I know that there are more questions, and I think at the end, if we have some extra time, we'll come back to them.
Rachel covered me.
Oh, good. Guess what? Bonus. You get to ask your question.
All right, my question has to do, sorry, my name is Fatima and I'm with Contra Costa County with alcohol and other drug services. So we are the providers that, provide the substance use treatment. And I'm referring specifically about residential facilities. When the clients go out on passes and then they can't come back with, there could be near to an overdose, but in residential facilities, staff, we don't have medical staff. These are social moral programs. Nor staff can administer medications or injections. Have you guys dealt with that already? Have you heard anything about it? Thanks.
Yeah, so we're talking to Community Recovery Resources, our major residential treatment provider for both Placer and Nevada counties, and they're very interested in this. Just in the issue that you bring up, we were looking at actually paying for them for everyone who is discharged from their residential facility with a diagnosis of opioid dependence to provide them with one of these units so that's one of the questions I have, actually, the discussion around naloxone coverage. These are people who are Medi-Cal eligible. I would think that would be an indicated use that would be covered under Medi-Cal, because this was going to break our budget, right? Yeah, so I don't know, that's a question I've actually had for DHCS, is wouldn't that be kind of covered? I know that the PO, kind of oral naloxone is, but in this case, you would think that there would be, this is such a high-risk group that they would have some sort of coverage for the intranasal. So,
Yeah, the Medi-Cal covers the naloxone intranasal for any indication. There's no prior authorization. They do need that atomizer, which is a couple bucks to attach to that, and they're right now going through the process to try to get coverage for the new formulations that are just all in one. So there shouldn't be any barriers in Medi-Cal.
Great, there we go, we learned something.
Yay, thanks.
Wonderful. All right. So thank you very much, Rob and Lindsay, for your presentation. Okay, so we are going to shift now to hear from our second coalition, which is Santa Clara, and for that we have a team of 3 people, so come on up. I will introduce you first to Dr. Karina DeBruyne. Did I pronounce that? Okay, good. She is an assistant clinical professor at the Stanford School of Medicine, and she's the clinical lead for the Santa Clara County Opioid Overdose Prevention Project, also known as SCOOP, right? Okay, and then we have Myra Parwiz, and she is the Division Director for Addiction Medicine and Therapy for the Santa Clara County Department of Behavioral Health Substance Use Treatment Services Department, and she is Dr. DeBruyne's co-lead for the SCOOP. And then we also have Cheryl Blankenship, and she began her career in Santa Clara County as a medical social worker. I won't read it word by word, but you are working in the department with Myra. Is that right? Great. Well, thank you very much.
Thank you for having us today. We're delighted to be here and be part of this coalition. And I think the reason we're here to share our success story of how we came to become a coalition and the things that we were able to do in Santa Clara County, just share our experiences. I have to start with basically how we came, because we did apply for a coalition grant. I think most coalitions got some money from California Health Foundation to do their work last year. But we didn't get it, but that didn't stop us. And we were still like, okay, it's okay, we didn't get it, but we're gonna go forward. And so I think what the driving force behind all of that was staff like Dr. DeBruyne, Cheryl Blankenship. They're all champions and saying, let's go forward, let's do this. But I have to also say that our county government has been very supportive. So because of all of this, a compassion and that strong will and the support of the county, we are able to launch our own coalition without any money from anybody, from public health or from the California Health Foundation. So, basically I'm saying that you can get it done even if you don't have the monetary money behind it. So if you have the will, go forward. So let's see if I can work this. Okay, so some of our successful strategy was that we put together the coalition. We got a lot of input from our own different communities surrounding who we work with. Public health, we brought public health, Department of Alcohol and Drug Services, mental health, the physicians, pharmacies, the Children Coalition, the Family and Youth Coalition. So we brought a number of the entities together, and then we start to form the coalition, and that's how we kind of had our hand in everywhere, trying to get the whole coalition together to be made up of different sections, basically, and represent the county that way. Then we start to engage our public officials. So once we had our members set up and we had goals set up based on the coalition, based on the California Health Foundation's goals, we went to our officials and we said, this is what we like to do, and they said, go for it. So that's how we did. And then we started to do targeted marketing. So we did partner up with the National Coalition on Drug Abuse Prescription. I keep forgetting the whole. Amy's, I'm sure, here. She can correct me. So we were partnered with them. They are one of our good partners that help with the youth and the prescription drug overdose issues. And also with the PTA, our children, family, youth section. They're very involved in the schools, and they go out in the community and provide this education and a campaign for us. And we also reached out to universities. We have worked with our student body and the different universities to get them involved and get the word out. And our interns, actually, we have interns working with us from like Stanford University, from Santa Clara University. So we've brought them to come and work with us and how to work back in their schools and get this word out. And then physicians, of course, we're lucky to have Dr. DeBrun with us. She's the champion on the physician side. So we kind of left it all up to her how to get our physicians on track on this. And then we're working our emergency rooms, and we're working with pharmacy. I do have actually one of our interns from pharmacy here. So we are trying to work with pharmacies, other members such as health plans. We do have 2 managed care health plans in our county, and we're working with them to get our physicians educated and provide some funding. So they also have agreed to do that going forward. I do have to say I'm a little bit struggling with our law enforcement. So I would need the help from Nevada if they can help us there. That would be great. And then the last thing, I guess, for those of you who know how to get your county and cities involved, is to basically do this kind of stuff that we did. Provide them with a big picture. So provide them with the facts and data. What's happening in your county? What's the cost? And the whole epidemic that's going on nationally, but then bring it home to them. This is what's happening in your streets, in your county, in your city, and how it's affecting your citizens. So once we got that, then we provide obviously the cost factor. So how many of those physicians, those members of the community are going to the emergency room? So you're paying for that. You know, all the law enforcement, now other things that are happening. If you add up all the cost, then they know that there's no brainer to really put that efforts towards this coalition and provide naloxone or provide more treatment access. So in a big, quick summary here, basically that's what we did, and that's how we got where we are, and where I'm very happy to say that we have launched our start distribution of naloxone program in the community. So we have distribution in our medication-assisted treatment programs, in our residential, and we have actually rolled out in the community. So anybody that now calls our for treatment to access program, our call center, they're automatically rolled into a dedicated line that provides them with all the information about where they can get naloxone in our county and where to get it for free, where to go to the different pharmacies. So, and I have to say the county came forward and paid for all the naloxone. So, and they're paid for naloxone. We're using the nasal. So that's just a quick summary, and then I'm going to pass on Dr. DeBrun. She's going to talk about the physician side.
So, integrating naloxone into primary care opioid prescribing guidelines. If you were to have a bad reaction to the opioid medication and stop breathing, we now have a medication that saves your life. It's called naloxone, and your doctor can prescribe it for you. Be sure to tell your loved ones how to use it and where to keep it. So this is basically embedded in the primary care guidelines. That I have put together pretty much the same way that the emergency room guidelines were formulated by San Diego. And in fact, I have updated the San Diego prescribing guidelines for the ED as well, and embedded naloxone in it. So I met with the emergency room directors last week, and they actually seemed pretty open to the idea. I'm very impressed that Monterey was able to get all of their emergency rooms to buy in, but then Santa Clara has a lot more emergency rooms. And you know, there was a little bit of pushback from some people saying, well, wouldn't that encourage people to have more risky behavior? And we were able to counter that with San Francisco's data, which shows first they rolled it out for the heroin users, and it showed a really marked decrease in mortality in their city. And then they rolled it out in their primary care clinics, and their data shows a 63% reduction in ED visits. So the data's there. So hopefully everybody will sign off on that. So, in terms of the primary care clinics, so again, I have naloxone embedded in the safe prescribing guidelines of opiates. And we're starting off at Stanford in trying to remind physicians of this. Primary care physicians have many, many things to keep track of. All the HEDIS measures, every time the patient comes in, make sure all their vaccines are up to date and their preventive care. And naloxone is just like one more thing that people aren't used to it, so it's very difficult to get people to remember. Even though everyone is willing, you have to remember it. So I'm working with the IT team at Stanford, and the idea would be that any time that the computer notices a third refill on an opiate prescription, and it does not see naloxone in the medication list, there would be a pop-up window to remind the physician to prescribe naloxone. And so once the physician prescribes it and it's on the medication list, it would stop appearing until a year later, because we want to make sure we keep the prescription up to date. So we don't have it rolled out yet, but that's essentially what we're working on. And hopefully for any other Epic users in the county, our IT department would be willing to share that little Epic patch. So this is from the ED safe prescribing guidelines that I wrote. So I added for the patient to read, if you take opiate medications daily, ask your doctor to prescribe naloxone used to reverse accidental opiate overdose. And hopefully patients will take responsibility for that as well. So those are some of the things that we're working on, and I also have to report a failure. in naloxone, which, well, we'll see what we get. But the idea we had, as you had mentioned, was to reach out to the universities and to have naloxone available, because obviously we know there's lots of risky behavior with substance use at universities. And the undergraduates at the various universities tell me that oxycodone and Xanax are readily available on campus. And so the idea was to include in the training of the residence assistants and the Greek life leaders training on opiate use, mixing with, the dangers of mixing it with alcohol, the fact that we now have opiates out there on the street that are illicit, that look just like Norco but have fentanyl in them, et cetera, et cetera. And then dispense naloxone for the resident assistants to have on hand in case someone has an emergency. But unfortunately, we were turned down. So we will keep working on that because we think that's an important goal as well.
I don't know that I'm going to use my slides very much. I've worked for the behavioral health department for 15 years or so, and I'm kind of the lead for the treatment side of naloxone distribution. So one of my barriers as far as getting naloxone in like our social model detox facilities as well as our residential treatment providers, probably 80% of our treatment providers are contract agencies. And I started first with the doctors that staff those agencies, because they all have doctors that have to sign off treatment plans and things like that. And the doctors are way on board. Doctors like, great, where do I sign? Can you give me a sample of a standing order? I told them I'll train your staff, and actually I've spent days training staff about how to do a train the trainer, about how to train people how to use naloxone so they feel more comfortable about it. And the agencies, the contracted agencies, have really just been resistant and worried about liability. And even when I say, you know what, your staff isn't dispensing this. I mean, they're not administering it. They're dispensing it based on a standing order, all perfectly legal. They're still nervous about it. So I guess I need more support around the legal end to really make that happen, because all our contracted agencies, we will provide them the naloxone. So, they don't have to do much. We have a one-page checkoff sheet that they fill out when they dispense it so we can keep some data. And we'll provide all the trainings. I'll go to your staff meetings. I'll give you my slides, whatever you need. And it's that piece that's just the hang-up. We did recently find out, the speaker in the last session talked about just kind of natural occurring relationships that really foster the growth of agencies. And one of our specialized homeless shelters, I would say, it houses a kind of folks with co-occurring disorders. And they have a staff member that also works for our county needle exchange. And the staff member was able to bring a bunch of naloxone kits from the needle exchange over to their shelter and start talking to people about it. And they're on board. They said, great, if people need it, administer it. And they're totally okay with their staff doing that. So I'm hoping that once more of the agencies hear that they'll go, oh, well, if Envision can do this, well, we can too. So I'm hoping it will spread and disseminate. So that's one of the kind of natural occurring things that have happened in our county just as a result of talking about it. Law enforcement, yeah, that has been a challenge. Our needle exchange is using the intramuscular naloxone because they have a needle savvy population. Yeah, I think that's the biggest things I want to talk about. Embedding it in behavioral health. One of the things I have found is peer support. One of our peer support trainers that helps kind of train CIT officers she heard my presentation and said, "Hey, I train CIT officers. Can I mention it to them when I train them?" I said, "Would you please?" And so we're looking at ways to help increase that collaboration for the police in that way. So we may get to them yet.
I forgot to mention the flyer that's on the table. So this is part of a educational campaign that we're ready to roll out for primary care physicians and as well as the emergency rooms. And so it includes information on how to prevent overdose, how to recognize overdose, and what to do in case of an overdose with pictures of the use of the nasal spray. And on the back side, an explanation of the Good Samaritan law, and also the locations of where residents of Santa Clara County can obtain a free naloxone kit.
So I got a good question from Chico, which was we keep sending it to the pharmacy, this naloxone prescription, and they keep saying the managed Medi-Cal plan refuses to pay for it. And what I advise them is to talk to the pharmacist, because a lot of pharmacies don't understand that for naloxone and buprenorphine and everything related to addiction, they have to bill the state directly. And if they just go in the habit of saying, well, the managed care plan doesn't cover it, you'd get stuck. So some pharmacists just need to be educated. And we do have a pharmacist with healthcare services who can call a pharmacy if you're having difficulty with that. But the second thing is I know that we have parents in the audience who have administered Narcan themselves to their children, who've gone through the terrible reality of seeing a child with either overdose or near overdose. And I'm wondering if any parents in the room want to say a word about that experience. I don't want to put you on the spot, but that's one of the things we want to do in future conferences. We had a parent speak at our last conference, and I think it's a really important perspective to add to this discussion.
Yeah, my name is Bridget Van Essen, and I have a son who overdosed in my house 5 years ago in another state. We had Narcan, the nasal Narcan. I was trained in how to administer it. Still in a stress situation, it's really difficult. So I would suggest maybe, another form, the easier one to administer. Luckily, my son survived. We came back here to California, and I tried to get Narcan because I read all the nice press releases from CVS and Rite Aid. I basically had to educate the pharmacist, and Rite Aid still isn't able to give it to me. So for parents who are in the midst of a struggle with their children with addiction, to go up to a pharmacy and ask for something and then hit a brick wall, that's really difficult.
Our pharmacy intern, stand up, say hello. So his project is going to be to have buy-in of all the major pharmacy chains in our county to provide naloxone without a prescription. So that already removes one barrier. And then additionally, we're hoping to get the news out that people can pick up free naloxone kits when needed at the locations that are specified on the flyer.
So in my parent groups, all the parents know in California you can get it without a prescription, but parents go to their pharmacy and the pharmacist doesn't even know.
Correct. So right now in our county, there's only, I think, 2 pharmacies that will dispense naloxone without a prescription, and that's going to be Larry's job to get all of the pharmacies, or as many pharmacies on board as possible within the county.
And this is a real problem, and the Department of Healthcare Services has an addiction pharmacist who's working really hard to get instructions from the state to pharmacies, so every coalition doesn't have to repeat going to this pharmacy and saying the same thing, but we can get instructions from the state down. So I'm hoping next year it's a different story, but I want to recognize it's not easy right now.
We are supposed to go to a break, but it's a 20-minute break, so if there were more questions, we could stay, and if the speakers can stay for another few minutes. Are there any other questions? Okay, we do have a couple questions, so feel free to go if you need to go, but we'll stay for another 5.
I'm from San Luis Obispo County. We also have a large Cal Poly, and you know, kind of popped in my brain. Oh my, yes, that's sort of uncharted territory. We have a pretty robust naloxone program within our addiction. As the prescriber, I know I write hundreds of them. But can you share what the philosophy behind the refusal for allowing the overdose kits to be with the residential, what did you call them?
The RAs.
The RAs, thank
yep.
you. Can you share with me what their rationale was?
So the word we got back from the university is we'll have to check and see if this fits our student body's behavior. So, you know, there's a lot of, I think, denial at all levels, unfortunately. Yeah. Right. So Santa Clara University actually has a student EMS service, and they are the first responders before the paramedics even get there, and about 75% of their calls is intoxication. And so even I could not convince them to train their EMS students, who are all pre-med essentially, to carry naloxone.
Hi, Jennifer with Stanislaus County. When you talked about the naloxone being covered by the county, was it county behavioral health, county public health, county general fund? What fund specifically paid for that?
Yes, for us was county behavioral health department. But we also went basically involved our county supervisors involved and got their bless. So that's why I think it went through. And but generally, yeah, it came from our behavioral health department.
Great, I thought I saw one more hand up over here. No? Any other questions? All right, well, thank you very much, Santa Clara, for your presentation.